Hello, my dear students. This is Dr. Rohith Daniel, the Orthopaedics faculty from DocTutorials. So, welcome to the live discussion of the recently concluded INI CET RDx program, where we had conducted around 20,
Recording
an
in
INI
progress.
CET pattern question for all the 19 subjects, and each of the test had around 20 questions. So I hope that the exam went well for you. Hello, Karthik. Did you write the exam? How was it? Good evening, Karthik. So we'll wait for 1 or 2 more minutes so that other people can also join in. I hope you all attempted the questions, and I hope the questions were not that hard. So how was the questions? Was it too difficult for you? Anyway, the questions that I had put for you were exactly based on the INICT pattern, and most of the questions that I had asked were directly taken from the previous year topics. So all these 20 questions are very important for your upcoming INICT exams. So this is going to be a very short, quick discussion of the important of the questions and their answers. I will not be touching upon the entire subject, so I'll be just telling you how to arrive at the correct answer, and I will also be discussing few important MCQs and other points that are associated with each of these questions. All right, so I'll start. So the first question: which of the following statements about osteochondroma is false? Can you give me the answer? What is the answer for this question? You can type your answers in the chat box, and if you have any doubts also, you are welcome to ask in the chat box. I'll be happy to give you the answers and clear all your doubts. What is the correct answer here? So let's discuss the options one by one. First option, it is not a true tumor. Is that correct? It is actually a correct statement. The osteochondroma, now we know that it's not a true tumor. It is actually a growth aberration. That is what we currently believe. Okay. Why is it a growth aberration? Remember, osteochondroma has a peculiar character. Usually tumors will grow on its own, isn't it? But in the case of osteochondroma will grow along with the growth of the child. And once the growth of the child stops, the osteochondroma will also stop growing, isn't it? So this means that this is not a true tumor. What is happening is that if you have a bone like this, you have the physis here. Due to some unknown reason, there is an opening in the periphery of the physis here, and the physis or the growth plate extravasates out or herniates out, and this will grow and form a osteochondroma. So it is not a true tumor. This is a correct statement. It is treated using extraperiosteal excision. Is that correct statement? Yes, extraperiosteal excision means that you are excising the tumor along with its periosteal covering. This is important. Why? Because some of the tumor cells may be seen inside the periosteum. So unless you excise the periosteum and the tumor, there could be a chance of recurrence. That is also a correct statement. Yes, Kalyani, Anuj, good evening. So all of you are absolutely correct. This is the correct statement here. It grows towards the nearby joint. This is a false statement, and this is the correct answer here. So if you look at the picture of osteochondroma, you can clearly see that this is the tumor and the nearby joint is your knee joint, and the direction of growth is how it always grows away from the joint, isn't it? It always grows away from the joint. So that is the correct statement here. And this is false. What is the option number D? bursitis is the most common cause of pain in osteochondroma. Is that correct? That is also a correct statement, because whenever there is an abnormal protrusion in the body, maybe it is a benign tumor, maybe it could be another swelling, maybe it could be an implant that you put inside the body. So whenever there is an abnormal protrusion, the body provides a cushion by forming an adventitious bursa around it, an adventitious bursa like this. And many a time there would be some inflammation of this adventitious bursa causing bursitis. And this is the most common cause of pain in osteochondroma. Always remember that it's not fracture or malignant degeneration or anything like that. It is a simple bursitis that causes pain in osteochondroma in 90% of the cases. So all of you are absolutely correct. The correct answer is C here. So shall we move on to the next question? Again, a true or false question. Which of the following statements regarding osteogenesis imperfecta is false? Can you give me the answer here? It occurs due to a defect in collagen 1A. It is characterized by multiple fractures of bone even with trivial trauma. Non-union is common. Blue sclera is seen. What is the correct answer here? So let's discuss the options one by one. First of all, if you look at the option A, it occurs due to defect in collagen 1A gene. Is that correct? That is correct. Collagen, col 1A is nothing but collagen type 1 gene. And remember, collagen type 1 is the most abundant protein in bone. So whenever there is a defect or deficiency of type 1 collagen, obviously there is going to be weakening of bone. It is characterized by multiple fractures of bones even in trivial trauma. Is that correct? That is again a true statement, isn't it? That is why we call this condition as what? Brittle bone disease. And what about option D? Blue sclera is seen in these patients, isn't it? That is also true. Yes, Anuj, Yashasvi, Kalyani, Gilda, all of you are absolutely right. The correct answer here is option C. Non-union is not common in osteogenesis imperfecta. In fact, union is normal. Union or bone fracture union is absolutely normal. The bone is weak, but even if it breaks, it will unite very well, but it will undergo malunion. It is not non-union, but malunion that causes the deformities. So option C is the correct answer. Very good, correct, very good. Anuj, you are also absolutely correct. This is the right answer. So shall we move on to the next question? Again, here the question is, which of the following statements regarding achondroplasia is true? Inheritance pattern is autosomal recessive. FGFR6 mutation is seen. Arachnodactyly is a feature. Bullet nose vertebra is seen on X-ray of spine. What is the correct answer here? So let's look at the options one by one. Okay. So inheritance pattern is autosomal recessive. Is that correct? No, this is a false statement. Inheritance pattern is autosomal dominant, isn't it? FGFR6 mutation is seen. Is that correct? No, it is FGFR3 mutation on chromosome 4. That is the mutation seen. Is arachnodactyly seen? No, arachnodactyly is not seen. Arachnodactyly means what? Spider leg shaped fingers or long spindly fingers, which are seen in which condition? It is seen in Marfan syndrome. And what is the feature in hand that you see in achondroplasia? You get tiny fingers called brachydactyly. Brachydactyly. That is the feature in achondroplasia. So what is the correct answer? Option number D. Bullet nose vertebra is seen on X-ray. I'll show you the picture. So this is your brachydactyly, where you have tiny fingers like this. This is brachydactyly, and on an X-ray you will see this kind of shape, which is the tip of a bullet. So that is why we call it a bullet nose vertebra. Bullet nose vertebra will be seen. Anuj, correct. Starfish fingers will be seen. Champagne glass pelvis on an X-ray. All these are features of achondroplasia. You're absolutely correct. All right. Achondroplasia, remember, is a favorite among examiners. So learn achondroplasia thoroughly. So moving on to the next question. A 15-year-old girl sustained a fracture in her right leg in a train accident. She presents with severe pain in her leg, which is not subsiding with analgesics. On examination, there is pain on stretching the toes. However, the distal pulses are present. What is the diagnosis? Is it crush syndrome, compartment syndrome, fat embolism, deep vein thrombosis? What is the answer here? Think this is a very straightforward question, isn't it? Yeah, this is the classical. Anuj, absolutely correct. This is the compartment syndrome. Compartment syndrome. What is compartment syndrome? Because of an injury to a limb or because of a fracture, there is going to be trauma and edema inside the muscles. So when the muscles become traumatic and edematous, it will swell up and it will increase the intracompartmental pressure inside a compartment, and this will cause collapse of the arteries and veins. What will this result in? This will result in ischemia of the muscles. What happens to an ischemic muscle? It becomes edematous again, and there is going to be a further increase in intracompartmental pressure, and this process goes on for a long time, and finally the entire limb becomes completely necrotic. Okay, so what are the features that you can use here? You can see here to make the diagnosis. Remember, the most important symptom is this. In the case of compartment syndrome, the most common symptom is pain not subsiding with analgesics. So if a patient with fracture tells you that I have severe pain, I have taken analgesics 3-4 times today, but my pain is not subsiding, then you have to think about compartment syndrome. And what is the diagnostic feature? Pain on passive stretch. Pain on passive stretch is the diagnostic sign. You don't have to look for anything else. Usually students confuse with this. Distal pulses are present. Remember, it is not necessary that the pulses have to be absent to diagnose compartment syndrome. Please remember that. Losing of pulse is a final step on or one of the late stage in compartment syndrome. So by the time pulses and all are lost, the limb is already ischemic. So you don't want to wait till that time. You just check for tendon or pain on passively stretching the fingers in the upper limb or the toes in the lower limb for examining for compartment syndrome. And if you're further in doubt, you can measure the intracompartmental pressure. So when you measure the intracompartmental pressure, if it is more than 30 millimeters of mercury, you call it as compartment syndrome. Okay, this is an important MCQ. Intracompartmental pressure more than 30 is diagnostic of compartment syndrome. And the surgery we do for correcting it is fasciotomy. Fasciotomy. All right. Next question. Again, a very, very important question, very often asked. A 46-year-old male presented to the casualty after an RTA with complaints of pain and deformity of the right hip. Diagrammatic representation of his clinical appearance is given below. Which nerve is at risk because of this injury? Is it the superior gluteal nerve, femoral nerve, sciatic nerve, or the common peroneal nerve? Tell me the answer here. I know all of you know this answer. What is the deformity that you see here? You can see that after the injury, this patient has a abnormal deformity of the hip here, isn't it? What has happened to the hip? It is flexed. Then what? It is flexed. It is abducted. And if you look at the foot, you can see that the limb is also externally rotated. So there is flexion, abduction, and external rotation of the hip. And this is seen in which condition? Which condition produces flexion, abduction, external rotation? It is seen in anterior dislocation. Anterior dislocation of hip. And when anterior dislocation of hip occurs, the femoral head goes and lies in the femoral triangle where the femoral artery and nerve goes. So there can be compression of the femoral nerve. That is the answer here. Very good, Anuj, Maya, Kalyani, all of you have got this correct. So absolutely correct. This is the anterior dislocation of hip. Okay. So dislocations of hips are very, very important for you. So this is a table that you have to learn by heart. Okay. Please learn this table by heart. This differentiates between anterior and posterior dislocation. Remember, posterior dislocation is the most common type of dislocation. Here, the deformity that you see is flexion, adduction, internal rotation. There will be shortening of the limb. The hip will go posteriorly, and posteriorly, what do you have? The gluteal region, you have the sciatic nerve, isn't it? So there can be compression of the sciatic nerve, and the patient can present with sciatic nerve injury features. Now, what about anterior dislocation? It is rarer when compared to posterior dislocation. And here the deformity is flexion, abduction, external rotation. So this is something that you have to learn by heart. Every other year you get questions based on this. If you know the simple fact that is posterior dislocation, it is fader, and anterior dislocation is faber, you can get many questions correct. Okay. And here there will be lengthening, and because the femoral head goes anteriorly, there can be compression of the femoral nerve and the femoral artery. Now the thing with INICT paper is that many a time they will not give you flexion adduction or flexion abduction like that. They will simply give you pictures like this. So what is this? Here you can clearly see flexion, adduction and internal rotation. So this is posterior dislocation. And here, as the question that I asked you shows in the picture, here you have flexion, abduction, external rotation, and this is your anterior dislocation. Okay. So please do not confuse between the two. Be thorough with the deformities. Again, in INICT, you can also expect X-rays. Okay. Again, the concept is just the same. You just have to look at the deformity that you see here. Okay, so here you can see that the acetabulum is empty and the femoral head is dislocated out. So this is obviously hip dislocation. Again, the same thing you can see here. The acetabulum is empty and the femoral head is dislocated out. But question is, which is anterior, which is posterior? Again, it is simple. Just look at the deformity. Here you can clearly see that the femur is in adduction. The femur is in adduction. So this means that this is a part of flexion, adduction, internal rotation. So this is your classical posterior dislocation. What about here? Here you can see that the femur is in abduction. Abduction means what? Flexion, abduction, external rotation is in anterior dislocation. So if you get X-rays like this, just look at the orientation of the femur. If it is adducted, it is posterior dislocation. If it is abducted, it is anterior dislocation. Okay. And finally, just an important point, there is a rare type of dislocation called the central dislocation, where what happens is that you have the femur like this and the acetabulum. The injury is so severe that the entire acetabulum completely gets destroyed and the femoral head will dislocate into the pelvis like this. So that is exactly what you see in this X-ray. The acetabulum is broken and the femoral head here is dislocating into the pelvic cavity. This is called central dislocation. Central dislocation. Okay, so this could be rarely asked for INICT. Okay, so these are the three important X-rays: posterior dislocation where you see adduction, anterior dislocation, abduction, and central dislocation where the acetabulum is broken and the femoral head goes inside the pelvic cavity. Okay, all right. Next question: a 23-year-old male presents after an RTA. He sustained a fracture of the right femur. He has a wound of 6 centimeters over the medial aspect of the right thigh with complete transection of the femoral artery. What is the Gustello-Anderson classification? It is grade 2. Is it grade 3A, 3B or 3C? What is the answer here? Quickly tell me the answer. So what is this Gustello-Anderson classification? It is a classification for open fractures. Open fractures. What are open fractures? fractures which are associated with the wound, not any wound, a wound that is deep enough that the fracture hematoma inside is communicating with the outside environment. That is called an open fracture. And open fractures are classified according to Castillo-Anderson classification. Yes, brilliant, Anuj, Gidla, and Eva Braden. Okay, so all of you are absolutely correct. This is type 3C, type 3C injury. If you have not got this correct, I will tell you the how this works. See, Gustlow-Anderson classification is mainly based on the size of the wound, but along with that, the severity of injury, is also taken into account. Okay, so if you look at the grades, there are grade 1, 2, and 3. In grade 1, the wound is less than 1 centimeter. Grade 2, it is between 1 and 10 centimeter. And grade 3, it is more than 10 centimeter. This is a very easy classification. But there is a big catch here. What is that? There are certain features that are labeled as high high energy injuries or grade 3 injuries. What are those injuries? Maybe the fracture has occurred because of high energy trauma, like a railway accident, or it could be there could be extensive soft tissue injury, or the fracture could be segmental or comminuted. There could be gross contamination, or there could be vascular injury. If any of these things are there, don't look at the size of the wound. It could be a 1 centimeter wound, can be a 2 or 10 centimeter wound, doesn't matter. If any of these 5 things are there, it automatically goes in for grade 3. So that is the point you have to keep in mind. The wound is the first criteria, but keep in mind these things also. Okay. Now, grade 3 is further classified into A, B, and C. What is 3A? 3A is where the wound is more than 10 centimeter. It is a simple wound. You can just suture it. That is all. Very simple fracture. Type 3B, what happens is that there is a large wound with soft tissue loss. A part of the soft tissue covering the bone is lost. So what will you have to do? You'll have to take tissue from some other place and keep it in the wound to cover the bone. Okay. So you have to do either a flap cover surgery or a skin grafting to save the limb of the patient. This is your type 3B. And type 3C is the severest form where there is a vascular injury which requires repair by the vascular surgeon. So let's go back to the question. Here there is a fracture, open fracture of the femur. The size of the wound is 6 centimeters. So you might think that it is type 2, but there is a catch. There is transection of the femoral artery. So if there is vascular injury, it automatically becomes type 3. What type 3? Type 3 A, B, or C? C, because vascular injury, femoral artery injury will require repair, isn't it? Otherwise, the limb is going in for gangrene. So, major vascular injury like femoral artery injury, which requires repair, becomes type 3C. That is the answer here. These are all basic concepts. You need to remember these for your exam. All right. Next question. 18-year-old male presents with swelling in his left hip and limping for the last 1 year. His X-ray is given below. What is the diagnosis? Can you tell me, is it GCT, fibrous dysplasia, ABC, or osteodysteoma? What do you see here? If you look closely, you will see that there is a lytic lesion in the proximal part of the femur like this. And because of this lytic lesion, there is severe bending of the femur like this. Yes, correct. Anuj, absolutely correct. Iba Bradin, absolutely correct. I don't know what your correct name is, but absolutely right. So both of you are absolutely right. Yes, yes. Vasundhara, Anuj, all of you are absolutely correct. I think all of you have got this correct. Here there is severe bending of the femur, which looks like the staff of a shepherd. This is called the, yes, absolutely correct. This is the shepherd crook deformity. Iba Bradin, absolutely correct. This is shepherd crook deformity, which is seen in fibrous dysplasia. That is the correct answer. Well done, well done. All of you are right. So we'll move on to the next question. Again, a very, very important topic. A 25-year-old male presents with TB of the right hip. On examination, his hip is adducted and internally rotated with shortening of 3 centimeters. What is the stage of TB hip? Is it 1, 2, 3 or 4? Can you tell me the answer here? So remember, TB of hip has 5 stages. Stage 1, 2, 3, 4 and 5. And the interesting thing is that each of these 5 stages will have its own classical deformities. And just by looking at the deformities, you can assess which stage the patient is in. And this is a very important question, very often asked. Can anyone tell me? Okay, so I think this was a little bit difficult. So I'll first show you this table. So this is a table that you have to learn for your exam. So there are 5 stages in TB hip. Stage 1 is a stage of synovitis, where the deformity that you see is flexion, abduction, external rotation with lengthening of the lower limb. There will be lengthening. In stage 2, which is early arthritis, there is flexion, adduction, internal rotation with an apparent shortening. There will be a shortening of small shortening, less than 1 centimeter. Okay. In stage 3, which is stage of advanced arthritis, there is flexion, adduction, internal rotation again, but here there is severe shortening, true shortening of more than 1 centimeter. In stage 4, which is advanced arthritis with subluxation or dislocation, here the deformity would be variable. And in stage 5, there is fibrous ankylosis, where the hip will unite together because of fibrous tissue between them. Because the hip is fixed, there is very minute movement that is possible there. But whatever the movement is, it will be very painful. That is stage 5. The first 3 stages are usually asked for your exam. They could ask a patient with TB hip comes, there is flexion, abduction, external rotation. What is the stage? It would be stage 1. And what about this question? There is flexion, adduction, internal rotation with shortening of 3 centimeters, which is more than 1 centimeter, isn't it? So what is the answer here? This is stage 3. Stage 3. Okay. So this is a table that you have to learn for your exam. At least the first 3 you have to learn. And if you learn that, you can answer these questions. So various permutations and combinations are possible from this table. Okay. Next question. A 5-year-old child presents with history of fall. He has sustained injury to his right wrist. His X-ray is shown below. What is the Salter-Harris classification? Is it type 1, type 2, type 3 or type 4? Can you give me the answer? So what is the Salter-Harris classification? It is a classification for physeal injuries. What are physeal injuries? Injuries involving the physis or the growth plate. Here you can see that there are 2 fractures. This fracture is in the diaphysis. It is not involving the physis, so you can ignore it. Here, the physis is also involved, isn't it? There is a fracture line going like this. So there the physis is involved. So basically the question is, what kind of fracture is this? Let me see. Yes, Ashaswini, Anuj, both of you are absolutely correct. This is type 2, type 2. So Salter-Harris classification is a little bit confusing for many students. I'll try and simplify it for you. See, in Salter-Harris classification, we are basically looking at the pattern of the fracture line and assessing what kind of injury or what type of injury it is. Okay. In type 1 Salter-Harris classification, there is a fracture line that passes through the physis like this. Simple, through the same line as the physis. In stage 2, this is type 1. In type 2, fracture line passes through the physis and goes above through the metaphysis. That is stage 2. In stage 3, fracture line passes through the physis first, then exits through the epiphysis. This is stage 3. In stage 4, fracture line starts in the metaphysis, goes through the physis and exits via the epiphysis. This is stage 4. In stage 5, there is partial or complete destruction of the physis like this. This is stage 5. And this is a prognosis based classification. Stage 1 has the best prognosis. Stage 2 will have good prognosis. 3 and 4 will have variable prognosis, and type 5 will have the worst prognosis. Okay. Now, how can you remember this more easily? You can use the mnemonic Salter. Okay. Type 1 is for yes or separated or same level where the fracture line is passing through the physis. A is above, fracture line passing above through the metaphysis. Stage 3 is lower or below where the fracture line is passing through the epiphysis. TE is through everything where the fracture line is passing through all the three layers. And stage 4 is rammed or complete destruction of a part or whole of the physis. Okay. So these are the 5 stages, 5 types. So let's look at the X-ray here. You can clearly see that the fracture line starts in the physis and exits through the metaphysis like this. So because it goes up, SA above, this is type 2. Now this triangular piece of bone that you see here has a name which can be asked, which is Thurston Holland fragment. Thurston Holland fragment. And because the whole thing looks like a boat with a sail, this is also called as sail sign. Two important MCQs, Thurston Holland fragment and sail sign. Both of them are seen in type 2 physeal injuries. Type 2 physeal injuries. Okay. Next question. A 45-year-old male presents with back pain and back stiffness for the last 3 years. His X-ray of spine is given below. What is the probable diagnosis? Is it lumbar spondylosis, IVDP, which is intervertebral disc prolapse, spondylolisthesis, or ankylosing spondylosis? I think this is a very straightforward question. I want all of you to answer this quickly. What is the answer here? Yes, correct. Absolutely correct, Yashaswini. This is ankylosing spondylosis. Why? This is a 45-year-old male with back pain and stiffness for more than 3 years. So any back pain for more than 3 months itself, you can think of ankylosing spondylosis in a man. Okay. And what you see in the X-ray here, this is an X-ray of the spine AP view. There is a central line like this, which is white or sclerotic, isn't it? This is what we call as the dagger sign, dagger sign. Yes, Anuj, Vasundhara, Kalyani, Iva Bradin, absolutely correct. All of you are correct. This is ankylosing spondylosis. The X-ray shows dagger sign, which occurs because of the calcification of the supra and interspinous ligaments. This is the reason for dagger sign. Okay. Next question. A 35-year-old male presented with paresthesias of his right upper limb for the last 6 months. The test shown in the image is positive. What is the probable diagnosis? What do you see here? You can see that the examiner is standing behind the patient and he is palpating the radial pulse of the patient, and he has asked the patient to turn to the same side. And he is expecting to palpate for a reduction in the pulse volume or sometimes even complete disappearance of the pulse, radial pulse. What is this test? Yes, Yashaswini, Vasundhara, Ivabradin, Amartya, absolutely correct. This is, what test is this? This is AdSense test, correct. This is AdSense test, and it is a test for thoracic outlet syndrome, thoracic outlet syndrome. And the test for carpal tunnel syndrome is what? We have Phalen's test, reverse Phalen's test, and Durkin's test. Durkin's test. So remember to study thoracic outlet syndrome and carpal tunnel syndrome. Both are very often asked asked as MCQs. Next. For which condition is the brace shown in the image used? Scoliosis, kyphosis, dorsolumbar spine fractures, or TB spine? What is the answer here? So what do you see here? You can see that there is a very long brace, isn't it? Going in the front as well as the back. It is starting from the top of the neck and is reaching till the base of the till the sacrum. So What brace is this? Can you tell me the brace, the name of the brace? Yes, many of you are getting the answer correct. Yes, this is a brace used for scoliosis. What is scoliosis? It is the lateral bending of spine. So in girls, especially adolescent girls, scoliosis can occur commonly. And when that occurs, one of the braces that we use, or the most important brace that we use, is this. Yes, Yashaswini, absolutely correct. Absolutely correct. This is the Milwaukee brace. This is the Milwaukee brace. Okay. Milwaukee brace. This is a previous year question, spotter for you. Remember, any brace that reaches the neck. There are a lot of spine braces, but you cannot miss Milwaukee brace. Why? Because it reaches to the neck. So any braces which is very long and is reaching to the neck, you can immediately think of as Milwaukee brace, and it is used in scoliosis, for correcting scoliosis. Correct. Very good. I think all of you have got this correct. Correct answer. Next question. Which of the following is not a feature of Essex low-pressure fracture? Fracture radial head, fracture coronoid process, interosseous membrane tear, or distal radio-ulnar joint disruption. What is the correct answer here? Essex low-pressure fracture is an important fracture of the forearm where there is a triad of injuries. What are those three injuries that you can see? Can you quickly tell me the answer? So in Essex, yes, Yashaswini, correct. You're absolutely correct. The answer here is fracture coronoid process. Okay. Essex low-pressure fracture has three components. One is radial head fracture, then interosseous membrane tear, and distal radioulnar joint disruption. So it is a fracture or an injury that involves the entire forearm from the top to bottom, or from proximal to distal. So initially there is fracture of the radial head, then there is injury to the interosseous membrane, and finally there is disruption of the distal radioulnar joint. There is no fracture of the coronoid process. That is the answer. Next question. This is a very interesting question. A 8-year-old child presented to the OPD with complaints of progressive deformity of the right elbow for the last 3 years. He had sustained an injury to the elbow 3 years back, which was treated with plaster application. Now he complains of paresthesias over the medial two fingers. What is the probable nerve involved and the diagnosis? So it could be either ulnar nerve palsy because of malunited supracondylar fracture, median nerve palsy because of the same reason, median nerve palsy because of lateral condyle humerus non-union, or ulnar nerve palsy because of lateral condyle humerus non-union. What is the answer here? It's a very long question. Was it difficult? Yes, Vasundhara, you have got it correct. The answer is D. Yes, very good, very good. Yes, Yashaswini, you're also correct. This answer is D. So this is a very long question, but you can approach it very easily by just looking at the last sentence. Okay. So the child has paresthesia over the medial two fingers. So which is the nerve that supplies the skin here in terms of sensations? The medial two fingers are supplied by your ulnar nerve. Okay. So it is an ulnar nerve palsy. It cannot be B or option C. Cannot be median nerve palsy. It is either ulnar nerve palsy due to malunited supracondylar fracture or due to a lateral condyle humerus non-union. Now the question is, can malunited supracondylar fracture cause ulnar nerve palsy? No. The problem in malunited supracondylar fracture is what? Cubitus varus deformity or gunstock deformity. There is no nerve injury there. But that is not the case with lateral condyle humerus non-union. Why? In lateral condyle humerus non-union, you get progressive cubitus valgus deformity. Progressive cubitus valgus deformity. This kind of deformity. When there is progressive cubitus valgus deformity, there will be stretching of ulnar nerve on the medial side here, and over the long term you get something known as tardy ulnar nerve palsy. Tardy ulnar nerve palsy. Okay. Now let's read the question once again. So this is a 8-year-old child who had a fracture 3 years back. Probably this child had a lateral condyle humerus non-union. Remember, this is a fracture of necessity. What is a fracture of necessity? It is a fracture that has to be treated with surgery 100%. You cannot treat it in any other way. You have to treat it by reduction and fixation with screw or K-wire. Okay. If you are not treating it like that, like in this case where plaster application was done, there will be non-union of this fracture, and because of non-union, this child is going to have progressive cubitus valgus. As long as the child keeps growing, the valgus deformity will also go on increasing, and this will cause stretching of the ulnar nerve, resulting in tardy ulnar nerve palsy. So that is what has occurred in this child. Okay, so the answer is D. So we'll move on to the next question. Find the true statement here. So this is a set of statements regarding two important fractures, Bennett fracture and Rolando fracture. Okay. Bennett fracture and Rolando fracture involve the base of first metacarpal. Bennett fracture is displaced because of pull of EPL tendon. Rolando fracture is displaced due to APL tendon. Both fractures are managed with plaster application. Can you tell me the answer here? What is the correct answer? So remember, both Bennett and Rolando fractures involve the base of the first metacarpal. And in the case of Bennett fracture, there is a fracture like this, intra-articular fracture of the base of the first metacarpal. And because of the fracture, the shaft of the first metacarpal gets displaced laterally. Why? Because of the pull of the APL tendon. The APL tendon is attached there and it will pull the fracture apart like this. In the case of Rolando fracture, there is no displacement because of the pull, but there is comminution. There is a comminuted T or Y-shaped fracture at the base of the first metacarpal. So let's read the questions once again. Yes, Pallavi, Vasundhara, Iva Braden, Kalyani, you're all correct. Statement A is correct here. Bennett fracture and Rolando fracture involve the base of the first metacarpal. That is correct. Bennett fracture is displaced because of pull of EPL tendon. Is that correct? No. It is displaced because of the pull of APL, abductor pollicis longus tendon. Option C, Rolando fracture is displaced due to pull of APL tendon. Is that correct? No. It is the Bennett fracture that is displaced because of the pull of APL tendon. Both fractures are managed with plaster application. No. Both fractures usually need surgery for correction. Okay. So the only option that is correct is option A. Yes, Pragati, you are also correct. Option A is the correct answer. The next is a very easy question. I think all of you must give me the answer. Identify the fracture shown in the image. It is a fracture of the pelvis. Is it Duvernay's fracture, crescent fracture, open book fracture, or straddle fracture? What fracture is this? Quickly tell me the answer. If you look at the image, you can clearly see that this is a 3D reconstruction CT image of the pelvis. And there are many fractures that you see here, isn't it? The right and the left superior pubic ramus is fractured. The right and the left inferior pubic rami are fractured. So bilateral superior and inferior pubic rami fracture, which is called bilateral superior and inferior pubic rami. 4 fractures. Bilateral superior and inferior pubic rami fracture is called, yes, Pragati, it is straddle fracture. It is straddle fracture. Okay. So there are many confusing fractures in the pelvis. Any of these can be asked. So remember, bilateral superior and inferior pubic ramus fracture is straddle fracture. What are the other fractures? Sometimes there can be an isolated fracture of the iliac wing here. This is called the Duvernay's fracture. This is Duvernay's fracture. Sometimes you can have a fracture like this, but it will enter into the sacroiliac joint. So fracture of the posterior iliac wing involving the sacroiliac joint. See, Duvernay's fracture is isolated. It is not involving any joint. But in case of this fracture, there is a fracture which is entering into the sacroiliac joint. This is what we call as the crescent fracture. And in open book fracture, there is disruption of the pubic symphysis, and because of the disruption, entire pelvis opens up like this. This is your open book fracture. So don't get confused. This is Duvernay, this is crescent, this is open book fracture, and this is straddle fracture where there is bilateral superior and inferior pubic ramic fractures. Okay. Next question. A 15-year-old boy presented with pain in his right shoulder for the last 3 months. The X-ray shows a lesion in the proximal humerus close to the shoulder joint. A biopsy from the lesion shows chicken wire appearance. What is the probable diagnosis? So I'll just draw a picture to help you understand this. This is the proximal part of the humerus. This is a child, 15-year-old child. So obviously the physis will be open and the glenoid will be somewhere here. And where is the lesion? Lesion is close to the shoulder joint. What does that mean? The lesion will be in the epiphysis. There is a lytic lesion in the epiphysis. So even if you don't read anything else, just remember this. Physis open. Yes, very good. I think all of you have got this correct. Anuj, Yashasvi, Vasundhara, absolutely correct. Here the physis is open and the lesion is in the epiphysis. What is this? Only one tumor can come like this. This is chondroblastoma, which is also known as, yes, Vasundhara, Yashasvi, absolutely correct. This is Codman's tumor. Don't confuse with Codman's triangle. This is not Codman's triangle, which is seen in osteosarcoma. This is Codman's tumor or chondroblastoma seen in children, where so when you take an X-ray, the physis will be open because it's a child and the tumor will be in the epiphysis. And when you take a biopsy, you get the classical chicken wire appearance. Okay, so that is the answer here. So can you tell me any other epiphyseal tumor in humans, which is the other epiphyseal tumor, but in that case, it occurs in an adult, the physis will be closed. What is that? Can you tell me? What tumor is that? That is GCT. Okay, remember GCT, the physis will be closed, but the tumor will be in the epiphysis. Epiphysis. Yes, Yashaswini, you are absolutely correct. If the physis is open and the tumor is in the epiphysis, it is chondroblastoma. If the physis is closed and the tumor is in the epiphysis, it is GCT. Okay. All right, then next question. A 15-year-old boy presented to the OPD with complaints of pain on his right upper leg for the last 6 weeks. He also has occasional episodes of fever. X-ray shows a lytic lesion in the proximal tibial metaphysis with surrounding sclerosis. What could be the diagnosis? So if you look here, there are several clues to the diagnosis, isn't it? There is some problem in the leg of the child, isn't it? And along with the pain, the child also has fever. So this means that there is some sort of infection, isn't it? So if there is fever, and this is an orthopedic exam, so probably there is fever because of something in the bone. So most probable cause is an infection. An infection of bone is what? Osteomyelitis, isn't it? Now, osteomyelitis can be of 3 types: acute, chronic, or subacute. Okay, acute is when the infection is less than 2 weeks old. Chronic is more than 2 months, and if it is between 2 weeks and 2 months, we call it subacute. And what is the duration here? 6 weeks. So it is a subacute osteomyelitis. And what is the subacute osteomyelitis? We know. Yes, Yashaswini, Iva Braden, Kalyani, KK, Pragati, absolutely right. All of you are absolutely correct. It is Brody's abscess. Brody's abscess. Okay. So that is the correct answer here. So look for the clues. Just by knowing that this is could be a subacute osteomyelitis, the answer is Brody's abscess. And the classical feature on an X-ray is a lytic lesion in the proximal tibial metaphysis with surrounding sclerosis. So learn this statement by heart, because this is the only way to describe Brody's abscess. There is no other way to describe it. Okay, so if in your question you have lytic lesion in the proximal tibial metaphysis with surrounding sclerosis, the answer is Brody's abscess. Now, how does this Brody's abscess occur? It is very interesting thing. So you have the proximal tibia like this. This is a child. So this will be the physis. This is the epiphysis. This is the metaphysis. Now, an infection starts in the metaphysis and there is pus and abscess formation like this. The pus tries to spread. But there is a thing here. See, one, the infective agent is of low virulence. It is not very aggressive. And the host immunity is very good. So, the host will produce large amount of sclerosis or tough bone around the abscess. Why? To prevent the spread of the abscess. So basically you get pus in the center surrounded by sclerotic bone. And when you take an X-ray, so you get the central pus will be seen as a lytic area which is surrounded by this sclerosis. This is a classical presentation of Brody's abscess. And remember another MCQ here. On an MRI, you get something called penumbra sign or rim sign. Penumbra sign or rim sign is classical of Brody's abscess. Please remember that. Okay. All right. Next question. A 13-year-old boy presented to the OPD with painful limping. He is a known case of hypothyroidism on treatment and weighs 70 kgs. On examination, his right hip is adducted and externally rotated. What is the probable diagnosis? Perthes, congenital coxa vara, slipped capital femoral epiphysis, or Tom Smith arthritis. What is the answer here? Very commonly asked question. Can you give me the answer? Yes, Vasundhara, Jayagumar, Kalyani, absolutely correct. This is the classical presentation of slipped capital femoral epiphysis. Now, what is that? This is a condition where the capital femoral epiphysis, which is nothing but the femoral head in the child, will slip or separate from the proximal femur and displace. That is called slipped capital femoral epiphysis. So, I'll just draw a picture and show you. So, this is the adult proximal femur. In the case of a child, the femoral neck area will have the physis, isn't it? The physis will be there. So you'll have the physis somewhere here. Now, due to some unknown reason, idiopathic reasons, there will be weakening of the physis. When the physis weakens, the entire femoral head, when the child walks, will subluxate inferiorly and posteriorly. The entire femoral head will subluxate inferiorly and posteriorly. And this is what we call as slipped capital femoral epiphysis. It is an idiopathic condition, but there are few important risk factors you need to remember. It is usually seen in males, that is boys, between 12 to 16 years of age. What happens between 12 to 16 years of age? This is the peripubertal age, isn't it? It occurs between the peripubertal age group. And what are the other risk factors? Obesity, hypothyroidism, and hypogonadism. And when all these things are there, there could be a weakening of the physis, and the child will present to you with painful limping. That is the sign. Painful limping will be there. And on examination, the child's hip will be adducted and externally rotated. Okay. Now let's look at the question once again. What is the age of the child? What is the age of the child? It is between 12 to 16 years, isn't it? The gender is also correct, boy. The child is presenting with painful limping, which is the classical symptom of slipped capital femoral epiphysis. Hypothyroidism is a known risk factor. Why hypothyroidism occurs? So, Pragati is asking what is the relation between hypothyroidism and slipped capital femoral epiphysis. We do not know the mechanism of how this happens. Okay, we only know that boys with hypothyroidism have a higher risk of getting slipped capital femoral epiphysis. Due to some reason, it causes weakening of the physis or the growth plate. Okay, that is all we know. And again, if you look at the next risk factor, the child is weighing 70 kg. So there is obesity. So the peripubertal boy, hypothyroid, obesity, presenting to you with limping, the hip is adducted and externally rotated. All the classical features of slipped capital femoral epiphysis are there. Okay. I'll just tell you what the other conditions mentioned here are. What is Perthes disease? It is a reversible avascular necrosis of femoral head in a child, and the age group is 4 to 8 years. What about congenital coxa vara? It is a condition where there is a deformity of the proximal femur in a child. The age group is 1 to 6 years. And what is Tom Smith arthritis? It is a condition where there is septic arthritis of hip in a child less than 1 year of age. So this occurs less than 1 year of age. So even if you don't know anything about the question that you mentioned here, if you just look at the age, you can see that Perthes congenital coxsavere and Tom Smith arthritis cannot occur at 13 years of age. It can occur only in only thing that can occur in this age group is left capital femoral epiphysis. Okay, so you can remember it that way also. All right. So our last question: which of the following findings is not seen in renal osteodystrophy? Low calcium, low phosphate, elevated PTH, or elevated alkaline phosphatase. What is seen here? What is renal osteodystrophy? It is a bone destroying metabolic bone disease seen in chronic renal failure. Chronic renal failure. And what is the classical lab finding in renal osteodystrophy, which is not seen in any other metabolic bone disease? Yes, very good, Kalyani. Yashaswini, absolutely correct. Low phosphate is the answer here. The classical finding in renal osteodystrophy is elevated phosphate levels. Please remember that the only metabolic bone disease where there is elevated phosphate level is renal osteodystrophy. All other conditions you will have reduction in phosphate levels. So you can remember this table for your INI CET exam. You can get questions from this table. So the lab findings in rickets and in osteomalacia are same, where you get a reduction or normal calcium level. PTH level, which is parathormone level, is elevated. Phosphate will be low. Alkaline phosphatase level will be high. In primary hyperparathyroidism, everything will be similar to rickets. Only changes elevated calcium. Renal osteodystrophy, everything will be similar to rickets except elevated phosphate. Page's disease, everything will be normal except elevated alkaline phosphatase. Osteoporosis, there is no biochemical abnormality. Remember, there is no biochemical abnormality in terms of calcium, PTH, phosphate, or alkaline phosphatase in osteoporosis. Okay. In osteoporosis, however, the markers of bone resorption, such as TRAP, will be positive. I think this was asked in the recent NEET exam. In osteoporosis, markers of bone resorption such as TRAP will be positive, but other common markers will be negative. Okay, so these are the things that you have to remember. So these were our 20 questions. Yes, Yashasini is saying that you can see a rugger jersey spine. That is correct. Rugger jersey spine is a very commonly asked MCQ. See, spine is a finding in renal osteodystrophy. That is correct. Okay. So do you have any doubts? If you have any doubts in these questions, I am happy to clear it for you. Even if it is not from any of these questions, we can spend some minutes on other doubts as well. No problem. Yes, Yashaswini, DEXA scan is used for screening and diagnosis of osteoporosis. Okay, that is correct. Any doubts or any clarifications that you want? I think we had a very nice interactive session today. And I thank all of the students who have taken their time out to attend this session. And you have been very good interactive students. So if you have any doubts, it doesn't matter if it is not from the 20 questions that we discussed. If you have any doubts now from orthopedics, you can feel free to ask, no problem. Hyperbratin is asking regarding bone scan differences. Can you be more specific? What bone scan? DEXA scan or bone scan for tumors? Is that what you mean? Okay, DEXA scan is similar to taking X-rays or CT scan. Okay, where you are just examining, taking CT slices of various parts of the body and measuring something known as the T-score. That is different. In bone scan, you are giving uh, a, a dye or a radioactive element to the patient to see if there is any increased uptake in malignant lesions. Okay, so they are completely different. DEXA scan can be used only for one purpose, which is to diagnose osteoporosis. Bone scan is mainly used for diagnosing metastasis. Okay. All right then. Thanks everyone for attending the session and all the best for your upcoming INI CET